Hi everyone, my name is Katrina. I'm in year 4 this year and I'm the junior academic rep for MECCSIG. And I'd like to talk to you today about periop medicine and acute care. And this topic is very important to being a good medical student and to being a doctor essentially, but it also comes up on exams here and there. So hopefully we can learn quite a lot together today. I'd like to give credit to the people who have done this lecture in the past who have basically just used their slides. So Nicola, who's currently in 5th year and who gave this lecture last year, as well as Connor and Kieran, who gave this lecture in the past and are now working as doctors. Here is my email on the screen. If you have any questions or anything, please feel free to reach out or to message me on Facebook. And we're going to have like a Q&A session face-to-face, so you can ask questions there as well. So without further ado, let's get into it. Okay, so periop medicine is all about caring for the patient before, during, as well as after their surgery, trying to optimize any conditions that they have at the moment, and trying to prevent any complications that can happen either from the surgery or from their conditions to start with. Okay, and acute care is just about caring for a patient who's quite unstable and trying to make them a bit more stable. This is actually part of the matrix. It's not really taught as well as the other conditions, I would say, in 3rd year, but it comes up on exams and you'll start to see it like in the hospital, in theatre, etc. Okay, so here you can see this is from the paper last year. So there were 2 questions on emergency medicine and about 5 questions combined on the 2 papers on periop medicine as well. So it comes up on the exams. And the questions aren't always extremely straightforward. So it's important to know this content pretty well. Okay. So we're going to go through quite a lot today. So it's going to be quite a long lecture. If you feel like you're going, to lose focus or you're tired and you just want to take a break, please feel free to pause the lecture and come back to it. And there's going to be some questions throughout to test your knowledge. But yeah, let's get into it. Okay, so let's go through the principles of anaesthesia. So it's very simple. You have 3 phases: putting the patient to sleep, keeping them asleep, and then waking them up again. So putting them to sleep is called induction, keeping them asleep is called maintenance, and then waking them up is called emergence, or taking them to recovery after that. Okay. And we always talk about the triad of anaesthesia, so the 3 components. The first one is obviously analgesia, taking away the patient's pain. The second one is amnesia or hypnosis, putting them to sleep or inducing a state of unconsciousness, so they can't remember anything or they can't feel anything. And the third one, which is not always applicable to every single surgery, is called paralysis. So paralyzing the patient so they don't move at all for the surgery, but we'll talk about that shortly. Okay, so you might be asking, what's the point of giving the patient analgesia if they're going to be asleep, right? They're not going to feel anything. What's the point? So there actually is a point to this. And the reason is, even though the patient is technically unconscious and they can't remember what's going on, their body can still physiologically respond to pain. So the reason why we give the analgesia is to sort of dampen that response to any painful stimuli. For example, the tube that's going through the vocal cords, or the incision that the surgeon is going to create. Okay. And there's a few other reasons, but I won't go through those. Right? Just know that there's all different types of medications we can give in classes, and we'll talk about that shortly. So you can give it through a drip, you can give it through a tablet, or you can give it through like a regional anesthetic technique, which we'll also talk about. All right. And then the next step is putting the patient to sleep or inducing a state of unconsciousness and of amnesia. Okay, there's many different types of drug classes that we can use, but the 2 most common that you'll see being used in theatre are propofol and sevoflurane. Propofol is called the magic milk of anaesthesia, so it actually looks like milk in the syringe, and that one is given through an IV. And then there's sevoflurane, which is an inhaled agent. And it will be delivered like through the ventilator, and then through the tube that the patient has in situ. Okay. All of these other medications that you can see here on the screen are not so much used in theatre, they're more used in an ICU setting. Okay. As a rule of thumb, the anaesthetist will prefer to use the IV agents to induce the patient just because they have a more rapid onset. And then for maintenance, they can either use the gases like sevoflurane, or they can use a continuous infusion of something like propofol. Okay. And then in terms of paralysis, okay, so the reasons why the surgeon would want their patient to be paralyzed, first one is if it's a very critical surgery. So for example, brain surgery, spine surgery, things like that. And then also it applies in the case of laparoscopic surgery, okay? There's two classes of medications that we can give to paralyze the patient. There's the depolarizing blockers and the non-depolarizing blockers. So the depolarizing blockers, that includes suxamethonium, is the main one you'll see. So it binds directly to the receptors, and it causes excessive depolarization to the point that it causes paralysis. Okay, so you'll see the patient like twitch just a little bit, and then they'll be completely paralyzed. And then the other agents are the non-depolarizing agents. So that's your rocuronium, etc. And these ones, they have more of a like antagonist effect at the receptors for acetylcholine. So they will inhibit depolarization and thereby cause paralysis. All right. So both of these medications work very, very quickly. And you'll find that the anaesthetist will draw them in a red syringe. It's like a safety precaution to remind themselves that they're about to administer a medication that's going to completely paralyze the patient. So paralyze their whole body, including their diaphragm. So they have to be ready to ventilate the patient after that. It's pretty interesting. Okay. You always hear there's the risk of the anesthetic. There's the risk of the anesthetic. Why is there so much risk with anesthetic? Okay. The risk is that all these medications that we give for pain relief, to induce a state of unconsciousness, to paralyze the patient, they can all cause the patient to go into a state of respiratory depression or to stop breathing altogether. Okay, can also cause them to be hemodynamically unstable, hypertension, bradycardia, and also a main risk, especially in somebody who's not fasted, is that because they're unconscious, they can no longer support their airway. They lose that gag reflex, and then they are at increased risk of having like an aspiration, causing a pneumonia. So that's the risk, and we'll talk about how we can mitigate those risks and how we can keep the patient stable. Okay, so how we do that is that we monitor the patient, right? So we use an ECG, blood pressure, SATs, capnography, which is the trace of the CO2 that's being exhaled by the patient and it's being detected by the ventilator, kind of looks like that. Okay, and we have all sorts of airway devices that we'll talk about shortly to keep the patient from having aspiration or from just like closing up their airway. We can support the patient's breathing with all sorts of oxygen devices, and of course the ventilator. And then we can support their circulation by using all sorts of drugs and fluids to keep their blood pressure and their heart rate stable. So in terms of all the airway devices we can use, I'll go through them from the least complicated and the least invasive to the most invasive. Okay, so the first one is the Goodell, right, which is this one over here. You might have practiced inserting it on some mannequins. Basically, its job is to push the tongue a bit forward, so it's not like obstructing the airway, and it can make it a bit easier for you to bag mask the patient. So they come in like 3 different sizes, depending on the patient's jaw size, and they're very, very easy to insert. Right? There's a version of the Goodell that can be inserted into the nose instead to serve the same function. So that's called the nasopharyngeal airway. All right, and then the 2 main ones that you'll see being used in theatre, in ED, and ICU are the LMA and the ETT. Okay, so the main difference between them is that the LMA, so you can see it over here, right? So it sits above the vocal cords, right? Whereas the ETT will go through the vocal cords. The LMA is quick. Okay, it's extremely easy to insert. All you basically have to do is you bring the patient's jaw forward and open it up, and then you shove it through. And the newer ones are designed to like take the shape of the patient's airway to create a really good seal. So they're very good. Okay. And then you have your ETT, the benefit with the ETT is that it has this balloon over here. Okay, so after it's inserted, the nurse will inflate the balloon. Okay, that keeps it stable, 1. And 2, it can prevent any aspiration of any gastric contents coming up. So this is the one that you'll see being used in a patient who is not fasted or a patient who is heavily pregnant. And then if all of these things aren't working and it's a critical emergency, the last line that you can do is a surgical airway. You basically cut through the cricothyroid cartilage here and then you create an airway that way. It's very rare and a lot of people are trained for it, but have never done it in their lifetime. Okay. And here are all the different medications that we can do to like raise blood pressure, so vasopressors, and all the medications that can also affect the heart's contractility if it's not pumping strong enough or changing the heart rate. But I won't go through them, just know that they exist, and feel free to read this slide if you're interested. Okay. All right, now it comes time to like wake the patient up, all right, in a safe manner. So what the anaesthetist will do is they'll kind of look at the surgeons to see like what stage they're at in the surgery, are they closing up, etc. So they will stop giving any further medication to give the patient the chance to like wake up and for the medications to wear off on their own. Okay. If the patient is quite sensitive to the opioids and it's still not breathing on their own, they can give them the reversal agent, which is called naloxone, to reverse that process. Okay. And then in terms of reversing the paralysis that we talked about, okay, so if the patient has been paralyzed for the surgery, you have to reverse that, otherwise they'll never breathe on their own. Right? There's two main agents that you'll see being used. There's neostigmine, and there is a newer one that's more expensive, which is called sugammadex. Okay, and so the way that the anaesthetist or the ICU doctor or whoever is doing it can tell that the patient has been reversed essentially is this thing here called the train of 4. It's very interesting. Try and see it in theatre if you can. Basically, they'll pop these two little two leads essentially on the ulnar side of the hand, and then connect those up to the machine, and the machine will give the nerve like 4 strong impulses essentially, and you'll see if the hand contracts or not. Okay, so if the patient is completely reversed, or in somebody who has never been paralyzed, all right, you'll get like 4 strong contractions like this. Okay, if the patient is completely paralyzed, you have absolutely no contractions. All right, and then there's everything in between. Right? Sometimes you have just like 1 or 2, or they're weak contractions. The machine can detect all of this and can give the anaesthetist a bit of information as to how reversed the patient is, or if they're still paralyzed. It's pretty cool. I've had it done on myself before. Okay, so there's this rare complication that can happen from an anesthetic, and it's mainly due to the inhaled agents like sevoflurane, like we talked about, or to one of the paralyzing agents, which is called succinylcholine. Basically, what happens here is that the person will have an inherited mutation in a calcium channel here, and it will cause excessive release of calcium from the sarcoplasmic reticulum, and that causes a sustained contraction, okay, of the muscles. So they're very, very rigid. They have an increased metabolism, increased heat production, and the patient is in quite a critical hypermetabolic state, and they can die very quickly. Okay, so the signs of this is that you'll see an increase in the end-tidal CO2 on the ventilator, because they have an increased metabolism, so you have an increased amount of CO2. Hypothermia, right, because they're really, really contracting their muscles. Tachypnea, tachycardia, and you'll see the rigidity. Right? So the management for this one is a medication called dantrolene. All right, and patients who have a family history and they want to find out if they have this, it can be diagnosed by a muscle biopsy. All right, so now let's talk about the regional techniques of anesthetic. Right? So we've talked about the GA, and now we're talking about regional. All right. Benefits of a regional technique is that the procedure can still be performed without having to put the patient through the GA and all the instability that can occur there. And so it's great for your patients that have a lot of comorbidities, etc. And even if you're still going to do like a GA, the anaesthetists can use like a regional technique, like a spinal, for example, before the procedure, such that the patient will have like good pain relief for up to 24 hours after the surgery. So it's really good. Right? There's two types, if you will. So there's like a nerve block where you you inject some local around a like peripheral nerve, for example, like a femoral nerve block, or there's the epidurals and the spinals, which go into the back into slightly different spaces here. So the epidural will go into the epidural space, which is so that's a potential space, or the spinal will go into the dural space, right? So into the CSF, and they're both really good as well. Okay, and then for your local anesthetic, so if you're suturing, for example, or there's a small procedure like a biopsy, you can just inject some local into the skin. Right, so you'll see the surgeons before they close up in surgery, they'll inject some local. Okay, so in terms of the ones that are injected into the skin, they're often combined with adrenaline. And the reason for that is that the adrenaline can cause some vasoconstriction around the area that they're applying it to keep the anesthetic there for a longer period of time to prolong its effect. Okay. The caveat here is that you can't use the adrenaline combination in the body parts that have like end arteries. So the finger, for example, or the penis. Okay. So there's a very, very small risk of toxicity with the local anesthetic, and this usually happens if it's inserted into an artery, and it can spread throughout the body. Okay, so the earlier signs is like numbness in the mouth, that's like ringing in the ears, dizziness, and then if it's really, really bad, can cause seizures, can cause a coma, respiratory depression, or can cause you to stop breathing, but that's quite rare. All right, so here we have a question. So this is a 70-year-old man who has undergone an elective transurethral prostatectomy under a spinal. And when he arrives in the PACU, he is noted to be hypoxic and is experiencing difficulty lifting his arms due to weakness. So have a look at the options. I'll give you a couple of seconds. You can pause the video and have a think about the answer that you want to give. Okay, the answer here is a high spinal. So the risk sometimes with the spinal is that the medication can travel higher up the spinal cord than was intended. And here you can see that it's traveled high enough that that it's affecting the nerve roots that supply the arm and supply the diaphragm. This is quite serious, but it's also rare. All right, so now let's talk about pre-procedural management or pre-op care. Okay, so let's talk about the diabetic patients. This is quite complex, I think, as a third year, but it came up on our exam last year. So basically, why do we care about diabetic patients? Right, they have a high risk of complications from a cardiovascular point of view, high risk of infection at the wound, and also have poorer healing of the wounds. Patients who have diabetes will often be at the first part of the operating list in order to prevent them from fasting for a long time, because they have an increased risk of going into DKA or HS. Okay, so patient who is diabetic and is going to have surgery, right? So you want to be checking their BSLs according to hospital protocol, and then for your type 2 diabetics, okay, so your non-insulin dependent diabetics, all right, depending on the medication that they're on, you have to stop it at a certain point in time prior to their surgery because they're going to be fasting. So you don't want them to take the medication and to be fasting because they'll have a hypo. Okay, so if they're on like an oral agent like metformin or something, you stop that on the morning of their surgery. However, and this came up on our exam, if they're on any SGL2 inhibitor, so any of the flozins, you have to stop it 3 days before their surgery because they are at an increased risk of euglycemic DKA. Okay, that came up on our exam. All right. And then if they are on insulin, if they are on the AM list, okay, so like a morning surgery, you don't give them the morning insulin, but you continue their basal dose, right? So you don't give them the fast-acting insulin, you just continue their basal dose. And then if they're on the PM list, they can have a light breakfast and then fast from 7 a.m. And they have their half of the bolus dose in the morning, okay? And to prevent them from having hypos, you can have them on an insulin and a dextrose infusion combined, okay? If you have a poorly controlled diabetic, you can consult the endocrinologist because they're the experts in diabetes. And then if you have any patient who's having like a symptomatic hypo, you can give them some dextrose through an IV, but you can still keep them fasted. It's quite complicated, but the thing that I would really pay attention to is the 2 points that are in blue here, because they're the ones that could come up on the test. This stuff, not so much. Okay, and then so let's talk about blood thinners, about anticoagulation. So obviously, there's the risks and benefits to these medications. There's always the risk of bleeding, but in terms of why we care for surgery, that there's going to be bleeding already. So the fact that the patient is on blood thinners could make that even worse. Okay, depending on the agent that they're on, and depending on the reason why they're on it, all right, that will determine our decision making in terms of do we stop it or do we continue it? If we're going to continue it, for how long and so on. Okay, so generally for aspirin, all right, if the patient is on it just for primary prevention, okay, so they don't have a stent or anything like that, we would stop it 7 days prior to their surgery. Okay, if, however, they've had a stent or they've had a stroke, all right, so this is now secondary prevention, we generally will continue it. It's okay because the benefits of being on the aspirin probably outweigh the risk of excessive bleeding. But again, it depends on the type of surgery. So if it's more critical that we don't have bleeding, like a neurosurgery or a retinal surgery, then we would stop the aspirin there. Okay. If they're on an agent like clopidogrel, we would cease that 7 days prior. If they're on like a NOAC, you cease that 2 to 3 days prior. All right. Generally, though, every single hospital has its protocols for these agents. And if you're ever confused, you can speak to hematology. Right? In terms of warfarin, there's a special protocol for warfarin. Okay, so normally we want to stop it 5 days prior to the surgery, but we want the patient to have some protection during that time. Okay, so there's this thing called like a bridging therapy. Basically, what that means is because warfarin takes some time to wear off, and it takes some time to actually kick in again, we'll stop the warfarin 5 days prior to the surgery, and then in between we can bridge with like a shorter acting agent like clexane. Okay, and then we can cease the clexane on the day of their surgery. If we ever want to reverse warfarin, if it's an urgent situation, we can use a vitamin K, because we know that warfarin inhibits the vitamin K dependent clotting factors 2, 7, 9, and 10. And then in an emergency situation where you really, really, really need to reverse the warfarin, you can give the patient fresh frozen plasma, okay, because that contains those clotting factors of 2, 7, 9, and 10. All right, so a few other medications. So in terms of your antihypertensives, you normally would stop them on the day of the surgery. And the reason for that is all those medications that we talked about prior, so the opioids or the propofol, for example, can cause the patient to already be hypotensive during the surgery. So you don't want the two medications together causing to be further hypotensive. And then in terms of steroids, so if the patient is on a high dose or is on like a regular dose of steroids is an increased risk of complications. Why? Because they're taking all those external or exogenous steroids. It suppresses their internal or their endogenous production of steroids. Okay, so if you were to stop the medication suddenly, they're at an increased risk of being hypertensive and hypoglycemic. Okay, normally, like, you would taper them down slowly, or you just check the hospital protocol. Okay, and then in terms of a few other medications, critical medications like anti-epileptics, cardiac medications, asthma medications, you can still give them on the day of surgery. And if it's a tablet medication, you just give it with a sip of water, so the patient can still remain fasted. All right, now let's talk about all the different post-op complications. This topic comes up a lot on the exams, so pay attention if you haven't been paying attention so far. Okay, so let's talk about the causes of post-op fever, all right, which was a question on Grey's Anatomy. Haven't watched it, but yeah. So post-op fever is defined as a raised temperature, which is generally greater than 37.5. And it's quite common to see this on your surgical rotation. It's usually due to some process that's going on, or it can be a direct cause of the surgery. Okay, the thing to keep in mind is that it's not always an infection. It can be, but it's not always. So depending on how many days after the surgery the fever happens, it can give you a clue as to what the cause could be. All right. So the way to remember the causes is the 5 W's: wind, water, walk, wound, and wonder about drugs / it's like weird and wonderful things. Okay, so the 5 W's help us to determine the cause. All right, so the first 1 to 2 days post-op, the cause is probably respiratory, so wind. For example, did the patient have an aspiration complication during the surgery and now they have a pneumonia? From 3 to 5 days post-op, we're thinking water, so urine. Did they have a UTI? From 5 days onwards, we're thinking about walking. Right? Has the patient mobilized, or did they have like a major orthopedic surgery and they're in a lot of pain and they haven't moved, which puts them at an increased risk of a DVT or a PE. From 5 to 7 days, we think about like a wound infection. So for example, is the wound infected? Is there an abscess or a collection near the wound? Do they have it's like a surrounding cellulitis, etc. And then from 7 days onwards, we start to think about all those other different causes. Is it a medication that they're on? Is it something that happened during the surgery? All right, things like that. Okay. Often in the exams, you'll see this word atelectasis. Okay. Technically speaking, okay, it's often cited as a cause of post-op fever, but the evidence suggests that it doesn't really cause that. All right, but like, what is this? Okay, it's the collapse or this incomplete expansion of the lung parenchyma, often because the patient is breathing very shallow, right? So their airways kind of collapse. So this is more common in your patients who have a lot of pain and it's painful to breathe. So they'll take very, very shallow breaths. Okay, so you can see here that the alveoli has collapsed, right, because of those very shallow breaths. In terms of preventing this from happening, you encourage the patient to take some deep breaths, and if they're in such severe pain that they can't do this, then you want to give them more pain relief. All right, you can also have them do some chest physiotherapy to help to expand those lungs, etc. On examination, the findings that you'll see is there's reduced air entries and crackles at the bases, and the key word here is that they will clear with coughing. Okay, so the crackles at the bases will clear with coughing. If you're concerned that this is like a brewing pneumonia, then you can do a chest X-ray or a sputum culture. Yeah. Okay. And then in terms of those other complications, right, so you have pneumonia. I won't go through this in too much detail because you'll probably have it discussed in your respiratory lecture, but the main thing to do with surgery is that you can have an aspiration, okay, of of the gastric contents, and they are quite like acidic. Okay, so the lungs do not like that. All right. Risk factors is if the patient had a GA, if they weren't fasted, if they have a history of really bad reflux or like respiratory disease, if they're a heavy smoker, etc. And then with UTI, so the risk factors for a UTI, female, if they're older, if they have a catheter that's been there for several days, or if they have diabetes. Okay. The way that you would check for this is you do a urine sample and you would send it for MCS, and you treat with antibiotics, etc. Okay. Quite common complication in people who also have a retention. Okay, so people have like BPH, for example, because stasis is the basis for infection. Okay. And then you have your DVT, PE. All right, this stuff is unfortunately very, very common. Okay, so you have your DVT, which is when it's still in a deep, like a deep vein, so usually in the calf, and then you call it a PE now if it has dislodged and it's ended up in the lungs. All right. Buzzwords for this: shortness of breath, pleuritic chest pain, coughing up blood, palpitations, syncope as well, which is not here, but syncope is a common sign, tachypnea, tachycardia, and also fever. Okay, so the investigations that we do for this one is an ECG, a CTPA, or a VQ scan. All right. In your patients who are pregnant or who are young female, we generally prefer the VQ scan because it's not as much radiation compared to the CTPA. And then if you're still thinking that it's at the DVT stage, you can do an ultrasound of the leg. Management is you want to obviously anticoagulate them. So it's usually heparin or DOAC. Okay, if it's a massive PE and they're unstable, then you would just go straight to thrombolysis. And if it's like a large enough PE, you can go and grab it through a surgical embolectomy. But ideally, we'd rather prevent this from happening than to treat it. So how do we prevent? Okay, so there's chemical ways to prevent and there is mechanical ways to prevent. Chemical ways is your Clexane. Okay, so most patients who have had surgery and haven't mobilized will be on Clexane or heparin. And then the mechanical ways to prevent DVT or PE is compression stockings. You'll find that patients are often wearing them during the surgery, after the surgery. Or there's these like type of like stockings that can like squeeze the calves every few minutes, which is called IPCD. And then obviously you want to get on top of the patient's pain so that they can mobilize quickly after the surgery and prevent this from happening. Okay. And then in terms of your wound infections, so what factors put you at increased risk? If the wound was already contaminated, for example, it's an open fracture, if it's a trauma, if the wound involved like a dirty area, so for example, if it was like a GI perforation and all the yucky stuff from the gut spilled out, if it's a trauma, like I mentioned, if it's a longer procedure, okay, so the wound is exposed to the air for a longer period of time. And then there's patient factors, like the fact that patient is old and immunocompromised, if they're a diabetic, because that automatically makes wound healing harder. If they're obese, for example, if it's in a wound and the patient is quite like obese, the fat can essentially trap the wound, and then all the bacteria can get stuck there and cause an infection. Okay, so how you manage the wound infection is you will swab the wound and you'll send that swab to find out the bug that's causing, so you can treat properly. You want to wash out the wound, plus minus debridement, depending on like where it is, the type of infection, and you want to give your antibiotics. Things that we can do to prevent this from happening is to give the appropriate antibiotics prior to the surgery. So depending on the type of surgery, the anaesthetist will give different antibiotics. Right? So generally with the antibiotics, we give them ideally an hour before commencing the surgery. Sometimes though you'll see them give it like right before the incision, but ideally you give them an hour before surgery. Okay, so the main antibiotics you'll see in surgery are cefazolin. Okay, so that protects against skin flora. And then if there's if it's a colorectal case or like a gynae case, for example, they'll add metronidazole to cover for the anaerobes as well. Okay, so here's a question. Let's have a read. 75-year-old man smokes 20 cigarettes a day, has ischemic heart disease, and has undergone an anterior section for carcinoma of the rectum. On day 7 to 9, he is generally unwell, has lower abdo pain and some distension, and is anorexic. He's swinging fevers to 39 degrees, and they took a blood culture because he was febrile, and that grew E. coli. Have a think about what the most common cause is, and I'll give you a chance to think. Okay. The cause here is a pelvic abscess. Right? So let's talk about the risk factors this guy has. 1, he's old. 2, he's a smoker. He has comorbidities. And he's had surgery on the rectum, okay, which is already like a dirty area because of all the fecal matter that's contained there. Okay, so he has a fever on day 7 to 9, which gives us a clue. He has the abdo pain, and he's got high fevers. And also the helpful hint as well is that he has grown E. coli, so that gives us an idea of where the problem is coming from. It's probably coming from the abdomen. Okay, so let's look at the other options it could have been. It's probably not going to be peritonitis because it's saying he has like abdo pain, but it didn't really mention that he's peritonitic. And it didn't really mention that it was the wound itself that is inflamed, but it's more abdo pain and distension. Tells us that there's a pathology inside the abdomen. Okay, so it's a pelvic abscess because that's where the surgery took place. Yeah. All right, one more question. 58-year-old woman who is a chronic smoker undergoes an open coli. On day 1 after surgery, she develops dyspnea, tachycardia, and a mild fever. And auscultation reveals reduced breath sounds at her right space. Her SATs are 92 on room air. Have a think about this. Okay, so the answer here is a pneumonia. So let's talk about this. Her risk factors are she's a chronic smoker, so her lungs are already not very good. And this is like day 1 post-surgery. So we're thinking wind causes either a pneumonia or atelectasis. But the things that give it away is that she's got like localized findings. Okay? She's got reduced breath sounds at the right base, and she's having some trouble breathing. So it's consistent with a pneumonia. She's a smoker as well. Yeah, it's pretty easy. And it's not going to be like atelectasis. It's not going to be a collapsed lung because there are still lung sounds. It's just reduced. It's a pneumonia. 55-year-old female complains of breathlessness and right-sided chest pain. She's febrile and she underwent, so this is basically a surgery to remove the tubes and the ovaries, in case you haven't heard of that before, and a total abdominal hysterectomy, so to remove the uterus, 5 days ago. Have a think about what this is. This one is screaming PE. Okay, so it's got all the characteristic findings: shortness of breath, unilateral chest pain. It's 5 days, so it's like fitting with a DVT PE. And probably what's happened here is that, you know, she's had like major surgery, she hasn't moved, and then she's got a PE. Our 82-year-old man, 3 days post right hemicolectomy for ischemic bowel, is on the HDU. He is noted to have a temperature of 38 degrees and he's delirious. On examination, his chest is clear and his abdomen is soft and with normal bowel sounds and mild tenderness at his lower abdomen. What could this be? Have a think. Okay, this one is a UTI. So risk factors that this man has is that he's really old. Okay, he's old and he's delirious. UTIs commonly present in the elderly with confusion or with delirium. All right. So that's a hint for you guys. It's very, very common. Some other things that it could be, you could have considered like a pelvic abscess because he had hemicolectomy, but it's 3 days post-op, so that's more fitting with the UTI cause. His chest is clear, so we're not worried about a pneumonia, and also his abdomen is soft, so that points us more towards a UTI versus a pelvic abscess. 17-year-old female presents with central abdominal pain moving to the right iliac fossa. She is febrile and is tachycardic. CT imaging shows a collection in her right iliac fossa. She's booked for theatre in 2 hours. Have a think about the most appropriate antibiotics. So this is most likely an appendicitis, and this antibiotics that you would give are your ampicillin or penicillin, gentamicin, and your metronidazole. Okay, so now let's talk about post-op pain. Why do we care? Okay, we kind of touched on it already. If the patient is in pain and they don't want to walk around, that increased risk of a clot. If the patient is in pain from breathing, they're more likely to take shallow breaths, and then they add an increased risk of a pneumonia or an atelectasis. And also, if the patient's pain is really, really troublesome, it's a barrier to discharging them on time. So it's very important for us to get on top of patients' pain after surgery. In terms of the approach we take, so we follow the WHO ladder for analgesia. Basically, the principles are we want to start with simple agents and then kind of increase depending on the patient's needs. Okay, so we start with the NSAIDs or paracetamol, and we can add things like a mild opioid, codeine. If it's a major surgery or if the patient's in a lot of pain, then we would go up a step to your stronger opioids. Commonly, you'll see after surgery patients are on endone, which is the brand name for oxycodone. And there's a few sort of other classes we can use as adjuncts. Okay. Some other considerations: if the patient has to fast, or if the patient has had like a really major surgery, they often have something called a PCA. So what that is like a setup, a machine that has, for example, fentanyl or oxycodone, and the patient will press a button if they're in pain, and the machine will give them a dose, and the machine is programmed to not give them more than is safe. Okay, that's a PCA. So it stands for patient controlled analgesia. Okay. I won't go through all the pharmacology stuff, but just basically know that there's paracetamol, okay, which is like a centrally acting NSAID. Okay, so it's not going to act at your peripheral COX enzymes. All right, you have your 2 types of NSAIDs then, and there's the non-selective and selective. So non-selective is your ibuprofen, naproxen, and that acts on both COX-1 and COX-2. The risks with that one is you have an increased risk of ulcers in the stomach, which causes GI bleeding. So if the patient has to be on non-selective NSAID for a long period of time, you want to consider also adding a PPI to prevent them from getting ulcers. It's also, it can cause some toxicity to the kidneys in somebody who has renal failure. And you don't want to combine it with the other 2 medications in the triple whammy. And then for your COX-2, so your celecoxib or paracoxib, and the way to remember that this one is selective is that it's got COX or celecoxib, so selective COX. So this one has more an effect on COX-2. However, it has an increased risk of cardiovascular complications. And then with your NSAIDs in general, because they they can also increase the production of your leukotrienes. They are not completely contraindicated, but there's a relative indication for your patients who have asthma, because that can cause bronchospasm. And then the adjunct agents that we can add, especially for neuropathic type pain, is pregabalin, gabapentin, which have an inhibitory effect at GABA, or certain antidepressants like your tricyclic or your SNRIs can also help for neuropathic pain, or for patients who have more complex pain where their brain has been sensitized to chronic pain over a long period of time. And then for the opioids, so you have your typical ones like your endone, morphine, fentanyl, which act at the mu receptors in the central pain pathways. The problems with these ones is that they can cause constipation, can cause respiratory depression in somebody who's quite sensitive to them, or if you give too high a dose, can cause sedation as well, and it makes quite a lot of patients feel nauseous and vomit. Okay. If you have an overdose, and this can come up on a question, I think it's come up in the past. If you have an overdose on opioids, the signs you'll see in a patient is they'll probably have shallow breathing or respiratory depression. They can be sedated. And the key word is they have pinpoint pupils. So pupils are very small. All right. So the reversal that you would give is naloxone. You also have your atypical agents, so tramadol, tapentadol. Okay. And they work in slightly different ways. And there's all sorts of different ways you can give an opioid. You can give it through tablets, through IV, transdermal patches, which is usually buprenorphine. I'll pronounce that. They're extremely good at controlling pain, but you don't want to use them for a long period of time because patients can become quite dependent or addicted, and there's also those side effects that you want to avoid. All right, 78-year-old woman has poorly controlled post-op pain, it should say post-op, after a right hemicolectomy, despite having a PCA which is giving her morphine. Sorry. She has a history of a moderate renal impairment, and this is her serum creatinine pre-op, which is high. Which of the following medications are contraindicated in this scenario? Have a think about the patient factors. So answer here is naproxen. So the reason for that is this is an NSAID, and it says that she has a renal impairment. So you don't want to give NSAIDs to somebody who has sick kidneys. Fiona is a 23-year-old woman who has been involved in a severe accident in which she sustained a traumatic pneumothorax and a fractured femur. After surgical correction of her problem, she's put on a range of medication to control her pain. This includes an analgesic drug with no anti-inflammatory activity. Have a think about which ones that could be. Sorry. So answer here is paracetamol. The reason for that is, remember, paracetamol is a centrally acting COX inhibitor. It's actually not fully understand how it works, but we know that it doesn't have any peripheral anti-inflammatory activity. Okay, so all of these other ones would have some sort of anti-inflammatory activity. All right. So aspirin is a peripheral COX inhibitor. It's an NSAID. Celecoxib is a selective NSAID. Hydrocor is a steroid which has anti-inflammatory activity. Ibuprofen is an NSAID, and I don't even know what this is. So it's paracetamol. 63-year-old woman suffers from chronic osteoarthritis, predominantly affecting her left hip and knee. This problem is severe and prevents her from exercising as she normally would. Her GP, aware of these problems, aware that she has had problems with gastric ulceration, prescribed a drug for her that is specifically targeted at COX-2. What medication is this? Oh, it hasn't mentioned the answer, but this is B, Celebrex. okay, because it's a selective COX-2 inhibitor, okay, so it's less likely to cause problems with ulcers in the stomach. Okay, now let's move on to talking about post-op nausea and vomiting. This is a very common problem. It affects approximately 30% of the population who have had a GA. And why is this a problem? Well, number one, it feels terrible to constantly feel nauseous and to vomit. So patients often feel very, very terrible. It traumatizes them, or it causes them to have quite a negative experience of their surgery. It can cause their hospital stay to be prolonged. And it can also put them at an increased risk of complications. For example, somebody can get an aspiration. Okay. So how we can prevent and treat this depends on the patient. Okay, there are certain patients that have an increased risk of post-op nausea and vomiting. Okay, so we can find out who those patients are, and we can give them prophylactic antiemetics to try and prevent this from occurring. Or we also have medications to treat somebody who is vomiting. Okay, so in terms of the risk factors, right, so there's this thing called the Apfel risk score, which basically tells us how at risk the patient is at having post-op nausea and vomiting. There are some people that just never have it, and some people that get it all the time. Okay, so the risk factors include being female, unfortunately. If you've had a past history of post-op nausea and vomiting, or you have a history of motion sickness, if you've had the inhaled anesthetics like sevoflurane or isoflurane, so that's the volatile agents. If you don't smoke, that puts you at an increased risk. If you're having quite an extensive surgery, or especially if it's gynae surgery, for some reason that increases your risk. If it's a longer surgery, and if you've had opioids, and if you're younger. So somebody like me probably would be at an increased risk. Okay. So again, in terms of prevention, we can give the patients antiemetics during their surgery to reduce the risk that they wake up nauseous and vomiting. And then also we can think about, could we change the regimen to decrease the risk that they will have this problem after surgery? So could we give them TIVA? TIVA stands for total intravenous anesthesia. So that would be a continuous infusion of something like propofol, instead of using the gases like Sevo or nitrous. Or could we just do a regional technique, and that way we don't have to put them through GA? So there's all these different medications we can give to prevent or to treat nausea and vomiting in the acute setting. Okay, the most common ones are highlighted in red here. Okay, so you have your droperidol or your metoclopramide, and they are D2 receptor antagonists. Okay, so they block the action of dopamine at the brain, and that can prevent nausea or treat nausea and vomiting. And then you have your very common one, which is Ondan. You'll see it used quite a lot in the hospital, and that is that's a serotonin receptor blocker. Okay, so they can be used either you can give it during the surgery and the patient is asleep to prevent them from having nausea and vomiting, or you can use it to treat it in the acute setting when it's happening. You can also give dexamethasone during their surgery. This is technically a corticosteroid, but it's been found to have some really good antiemetic properties. So, and then sometimes you'll see a combination of the drugs, especially if the patient has had a really bad history of this. Okay, so let's do some questions. Which of the following complications is most likely to occur? 40-year-old non-smoking, anxious female with a strong history of motion sickness is undergoing a lap sterilization. It's pretty obvious that she's going to be at increased risk of post-op nausea and vomiting. Her risk factors are she's quite young, she doesn't smoke, she's anxious before her surgery, she's female, she has a strong history of motion sickness, and she's having laparoscopic gynecological surgery. So she's got all the risk factors basically. So she's at a really high risk of this happening. 24-year-old woman is complaining of nausea and vomiting 3 hours after a DNC. DNC, by the way, is type of gynae surge. So choose the most appropriate first-line drug therapy for her nausea and vomiting. Answer here is Ondan. It's the most commonly used in the hospital. It's fairly safe. So you just want to go with that one. Other complications, post-op bleeding. There's different categories or classifications depending on when the bleeding happens. If it's bleeding that's happening during the surgery or during the intra-op period, we call that primary hemorrhage. If it's bleeding that's happening within 24 hours of the surgery, we call that a reactive or a reactionary hemorrhage, and that's usually due to vessels that were closed or were just not bleeding during the surgery, starting to bleed after, or it can be that the surgeon just missed a vessel that was still bleeding and closed up the patient and thought that they were fine, but they're actually not. Okay. And then there's your secondary hemorrhage, which is a hemorrhage that's happening 7 to 10 days after the surgery. Okay, so this one is because you have an infection that's brewing, and that spreads into a vessel and kind of like erodes the vessel, so it kind of breaks into the vessel, and now the vessel is bleeding. Okay, so let's apply what we just learned to this question. Please select the most likely diagnosis based on the patient scenario. 45-year-old woman develops acute shortness of breath and stridor 4 hours after total thyroidectomy. Her pulse oximeter is showing SATs 90% on room air. And then they take off the dressing and find that she has a swollen neck. So it's okay if you don't know this, I'll explain it shortly. Okay, this is what we call a reactionary hemorrhage. Okay, so remember, she's 4 hours after her surgery. So this is bleeding that's taken place after the surgery, but it's within 24 hours. So we'll call it a reactive or reactionary hemorrhage. So what's happened here is the thyroid, which is quite a vascular organ, right? If you're trying to take that out, you have to ligate so many teeny tiny blood vessels. And you'll know this if you ever scrubbed into a thyroidectomy. Basically, the whole surgery is trying to ligate all those small blood vessels. Okay, so there's no bleeding into that very small space in the neck, the pretracheal fascia. Okay, so what's happened here is the surgeon probably missed some vessels that were still bleeding, and now she's bleeding into the pretracheal fascia in her neck. So that's why her neck is swollen. This is an acute emergency, and I'll talk about it in a coming slide. It's very, very serious because the pretracheal fascia is where the trachea is. So if you have bleeding that's brewing in that space, it's going to impinge on the trachea, and that's why she's having trouble breathing, and she's having stridor, which is a sign of upper airway obstruction. So that's why her SATs are low as well. This is very, very serious. So it's a reactionary hemorrhage. 45-year-old man was referred to a surgeon for bleeding PR and lumps at the anus. He underwent a colonoscopy. The only findings were large hemorrhoids, and the hemorrhoids were treated with an open hemorrhoidectomy under GA. On the 10th post-op day, he noted a cup full of blood in the toilet pan as he moved his bowels. What's going on here? This is a secondary hemorrhage, and the giveaway is that it's 10 days post-op now, so that is fitting with a secondary hemorrhage. There's probably some infection that's caused erosion into the nearby vessels. Okay, so let's go through some surgery-specific complications that are relevant to third year, but also come up a lot in questions, come up a lot in the exams. Okay, so with thyroid surgery, there's quite a few complications, and I actually got quizzed on this by a thyroid surgeon. So it's very, very good to know. Okay, so the first complication, which makes sense, is that the patient can have hypothyroidism because they've lost that endocrine gland. So they're going to be on hormone replacement through thyroxine. Okay, a few other common side effects. Because the thyroid is close to the recurrent laryngeal nerve, it can be nicked in the surgery, and if you injure one of them, you get hoarseness of voice. If you injure both of them, you can't speak anymore, right? Because the recurrent laryngeal nerve is a nerve supply to your voice box, essentially. Okay. you have the risk of a post-op hemorrhage. This is usually the reactive hemorrhage, the hemorrhage within the first 24 hours. So basically, the thyroid sits with the trachea in the pretracheal fascia. Okay, and as I mentioned, the thyroid is a very vascular organ. It takes ages to remove it, and the surgeon's basically sitting there painstakingly ligating every single vessel, and then they do a few checks after the thyroid is out to ensure that there is no bleeding vessel. Because once they close up that pretracheal fascia, they have to make sure that there's no bleeding. Otherwise, it's going to bleed into that space with the trachea, and it's going to impinge on the trachea, and then the person's going to have trouble breathing, and they could die very quickly because it causes upper airway obstruction. So that's the case that we saw in the question earlier. And the way to essentially treat that, it sounds pretty intense, is you have to open the sutures and to open that space again, because otherwise the patient is going to die from the pressure on their trachea. And then another consequence of the surgery is you can take out the parathyroid glands, or you can injure them. So that would cause you to have low parathyroid hormone, which would cause you to have hypocalcemia. So generally the surgeons try and preserve the parathyroid glands, or there are certain ways to try and to re-implant them if they think that they've taken it out by accident, and they basically do that by injecting them into the sternocleidomastoid muscle. I don't know how it works, but it's very cool. But that's also a complication of your thyroid surgery, thyroidectomy. Okay. Now, in terms of gallbladder surgery or any surgery on the bile ducts, you can cause an injury to the ducts, which means you can have like a biliary leak, so the bile is leaking. That would cause you to have obviously right upper quadrant pain, nausea, fever, anorexia, etc. These two, the next ones on bowel surgery, come up a lot on exams. Okay, so any type of bowel surgery, anytime you're having surgery on the bowel, you can have a risk of the contents basically coming out. So that can either be because you've had a perforation, so the surgeons have accidentally made a hole in the bowel, and now the contents are spilling out into the abdominal cavity, causing you to be peritonitic. Or if the surgeons are removing a portion of bowel and then they're trying to bring together two parts called anastomosis, which you can see over here. If they haven't done that properly and there's a hole or a leak, okay, so that's called an anastomotic leak. Signs of that: abdo pain, peritonism. So basically, the abdomen is rigid. Any type of palpation causes pain, or even just percussion. Percussion tenderness is a sign of peritonism. So that's really, really bad. They'll obviously be febrile, and if you don't treat that, they can deteriorate very quickly. Sepsis can be hemodynamically unstable. So how do we treat it? We keep them on bowel rest. You give them IV antibiotics, and if it's quite a major leak, you want to take them back to surgery and fix that leak. Another complication of bowel surgery is you can have a subphrenic collection, and because it is subphrenic, it's going to activate the phrenic nerve, so you'll get the shoulder tip pain because of the shared nerve roots, and you'll have a fever as well. Same principles: IV antibiotics and drainage if there is a collection there. Question: the following patient has undergone a procedure to their thyroid. Please select the most likely complication from the list below. 48-year-old woman is admitted to the surgical ward after a total thyroidectomy after a fine needle aspirate, so that's a biopsy, revealing a papillary thyroid carcinoma. Her surgery was difficult with some intra-op bleeding. The day after her surgery, she was well with minimal pain. However, she describes tingling around her lips. What could this be? Have a think. Answer here is hypocalcemia. So the thing that gives it away is the tingling in the lips. That's sign of hypocalcemia. And probably what has happened is that they've taken out her thyroid, or they've taken out thyroid, and then in doing so, they've taken up the parathyroid glands that sit behind the thyroid, and they haven't been able to reimplant them. So she's got hypocalcemia and she'll probably need supplementation of that hormone. Select the most appropriate intervention. 30-year-old woman underwent total thyroidectomy for a large papillary carcinoma. Surgery was difficult and she required 3 transfusions, so quite a lot of bleeding. A few minutes after she was extubated, so that means that the tube, the endotracheal tube has been taken out, she develops severe stridor and is some degree of respiratory distress. Which intervention, if carried out, is most likely to resolve the stridor? I think we kind of touched on this. Answer here is tracheostomy. So basically, you have to open up the neck again. She is bleeding into the pretracheal fascia, and if you don't cut open the neck again, she's going to asphyxiate and die. Pretty critical stuff. Select the most likely cause of the post-op fever. 65-year-old man undergoes an anterior resection for rectal cancer. On the 7th post-op day, he develops lower abdo pain with high fever. Abdo exam reveals tenderness and guarding in the lower abdomen. What could this be? This one's a bit tricky. The answer here is an anastomotic leak. Now, other answers that it could have been include a pericolic abscess because he's had surgery on his rectum. But the thing that points more towards a leak is that, one, he's had a resection, so the portions of his bowel have been joined together. So there's been that type of surgery. And the guarding in the lower abdomen tells us that probably is peritonitic. Okay, so the thing that often comes up in questions with peritonism is an anastomotic leak. There's something leaking into the peritoneum, which is causing it to be so irritated. Select the most appropriate management. 70-year-old man underwent an elective bilateral open inguinal hernia repair, I'm guessing, under spinal. He has a history of ischemic heart disease, chronic renal impairment, BPH, hypertension, and COAD. 8 hours after returning to the ward, he started to complain of central lower abdominal discomfort and was noted not to have voided, so not to have urinated, since returning from theatre. His blood pressure was 150 on 90, his pulse was 90. His other observations are within normal limits. Examination revealed tenderness over his suprapubic region over his groin wounds. He has suprapubic dullness on percussion. What's going on here? This is a tricky one as well. Okay, so you want to insert a catheter. Let's talk through this, okay? He hasn't voided. He hasn't been able to urinate. And in the context of he has BPH, he's an old man, he probably has BPH, and maybe he's also dehydrated, etc. He's probably in retention. The signs of retention: 1, he's got pain in his suprapubic region. That's because his bladder is really distended and trying to push urine out, but it can't because of the BPH. And he has dullness on percussion in that area, which tells us that there's fluid there and there's a really big bladder. So you want to relieve him of his discomfort and insert a catheter. I don't know if any of you guys have seen this, but people who are in retention are in agony, because try to imagine you really, really want to pee. Your bladder is very, very distended and you can't because of obstruction. So you want to insert a catheter to relieve this man. All right, management of the deteriorating patient. So you can't fail if you fall back on your doctor's ABCD. Okay, it used to be an OSCE station. Now that we have apexes, it's probably not going to come on your apex, but it comes up in your 4th year GP apex. You could get a basic life support station. And also it's just really good to know, in case you're ever the first responder in the hospital or in the community, how to approach the unwell patient. You can't fail if you go back to doctor's ABCD. So D, danger. So you want to check that there's no danger to yourself. If the patient is actively bleeding, you want to put on some gloves. If the patient has been electrocuted, you want to make sure that source has been turned off so you don't get injured yourself, etc. Okay, you want to check for sharps, things like that. All right, so that's what is meant by danger. Response, you want to check if the patient is responsive. So ways you can do that is verbal, ask them, can you hear me? Give them painful stimuli. So trap squeeze, you squeeze the trapezius muscle really hard. And if that's ever been done to you, it's very painful. We don't really do the sternal rub as much anymore just because it can cause trauma, it can cause injury. So we stick to the trap squeeze. Sometimes you'll find some doctors, they will squeeze the nail bed, and the way that they do that so it's painful is they'll have a pen, essentially, and they'll put it on top of the nail bed and then squeeze on top of that pen. That's really painful. If the patient is not responsive to pain or to voice or anything like that, we can say they are unresponsive. All right, at this point, you want to send for help. In the community, you would call 000. In the hospital, you press that big red button on the wall, which is the emergency buzzer, and you want to get the right people in the room. Then, so we're up to A, so you want to check their airway. Signs that somebody has an intact airway, very simple, is they're talking, all right? Because in order to talk, you have to have an intact airway. If they're unconscious, you want to check, is there any obstruction? Is there something that they're choking on? So you want to tilt the head back because that can open up the airway, straighten out the airway. And then you want to do something called a jaw thrust. So you can see over here, you kind of stand behind the patient and you kind of just look over their head, and you want to put your fingers under the angle of their jaw and thrust up. Okay, so that can keep their airway open and prevent their tongue from occluding their airway completely. You can also put in all the airway stuff that we talked about, but let's just go through BLS for now. Okay, so your Goodell, things like that. If there's any vomit that you can see that's obstructing their airway, in the community, you don't want to use your own fingers because the patient can bite on your fingers. So you use their own fingers to kind of get the vomit or whatever is obstructing their airway out. In the hospital, you just get the suction from the wall to suction any vomit or any secretions out. Then breathing. First step, are they breathing? So the ways that you can check if they're breathing is to follow rates. One, like their respiratory rate. A, have a listen to their lungs. T, check if their trachea is deviated. Check their effort. For example, are they like overdosed on medication like opioids to the point where they have respiratory depression and their breathing is not very regular at all? Okay, and you can assess if they are breathing by putting your hand on their chest and seeing whether their chest rises and falls, looking at their chest from the side. You can put your hand as well on their mouth and see if you can feel any air that's being breathed. And then you can check their SATs, of course, in the hospital. Okay, to help them with their breathing, you can use all sorts of oxygen and delivery devices, and MECCSIG has a really good fact sheet on this as well that was posted last year, and you want to aim for SATs between 94 and 98. Okay, if the patient is not breathing or their breathing is very irregular, okay, at that point you start CPR, 30 compressions to 2 breaths. So with circulation, you want to check, do they have a pulse? If there's no pulse, start CPR and get that ball rolling. If they have a pulse, you want to figure out how strong is it, okay? Is it regular or is it irregular? Are they in some sort of arrhythmia that's causing them to be unstable? Check their heart rate as well. And you want to check how perfused they are. So if the patient is not well perfused, they're going to be cold, have cold extremities. You can check their cap refill. If it's more than 3 seconds, they are not well perfused. Check their blood pressure. If their blood pressure is low, or if they have no blood pressure at all, if they have no pulse, then you want to obviously get two large bore cannulas, get your IV access, give them fluid bolus. All right. If there's frank bleeding that you can see, you want to try and stop that. So compress the wound, transfuse blood if needed, take them to surgery. It all depends on what's going on. And you can check the JVP. And then, so this is the part that's probably new to you in 3rd year, because you've probably learned that D is for defib, and that's in the community. In the hospital, your primary survey, D stands for disability. and that includes diabetes and drugs. So how do we assess disability? This is trying to assess their neurological status. So you want to take, do an assessment and find out their GCS. GCS, if you haven't heard of it, it's the Glasgow Coma Scale. It's a measurement of how aware or how alert the patient is. Okay, so the highest score you can get is 15, lowest you can get is 3. And if you're interested, you can go on MD Calc and search up GCS and figure out how it's calculated. Okay, if the patient has a GCS that's lower than that's 8 or lower, we generally say that they are probably so deep that they can't support their own airway. So at that point, you would probably intubate them. Okay, so GCS to measure how neurologically intact they are. Okay, you also want to check their pupils. Okay, so you flash a light into their eyes and see whether their pupils are equal and reactive to light, which is commonly abbreviated to PEARL. Okay, if the patient is awake or is not in cardiac arrest, you can check. You can do like a neuro exam on them to check for any motor or sensory defect. And of course, DEFG, don't ever forget glucose. You want to check their BSL because that could be the cause of them being so unstable if they're having a really bad hypo. All right. And there are 2 ways you can check their sugars. You can do finger prick, or you can take a quick blood sample and send it for a VBG, which is a venous blood gas, which gives you a lot of information about the patient very, very quickly. It can give you the hemoglobin, can give you the critical electrolytes, can give you their sugar, and can give you like a venous blood gas as well. So you can see their lactate, you can see if their acid base is out of whack. Okay, and then E is for exposure. So we want to check, have we missed anything else? Does the patient have a temperature? Do they have any rashes? Do they have any injuries that we can see? Okay, so that's your primary survey. That's your approach to the unwell patient. You can't go wrong if you follow this until the right help comes to help you. Yeah, so this is the types of shock. So basically your patient has low blood pressure, they're hemodynamically unstable, and you're trying to figure out why. Okay, this doesn't really come up on third-year exams, but it's super high yield for just being a doctor in general, and it makes sense. So there's 4 different types. Okay, let's go through them. Cardiogenic shock is when the heart as a pump is not working, it's failing. So that could be because the myocardium is injured, for example, in acute heart attack, or like a valvular failure, but the heart as a pump is not working, and that's why your blood pressure is low. Usually your heart rate will be high to compensate for the low blood pressure, and you'll find that the JVP here is elevated. The reason for that is because your heart as a pump is failing. So there's a backflow, or there's a backlog of blood in the venous system. So you'll see that the JVP is going to be higher. All right, and then another way that we can distinguish the types of shock is to have a feel of the patient's peripheries and see if they're cold or warm. So in cardiogenic shock, they're going to be cold because the cardiac output is not going to be too good. Okay, so cold peripheries in cardiogenic shock. Hypovolemic shock is because you don't have enough fluid or enough volume in your circulation. So if you've had a major hemorrhage usually and you're losing blood very quickly, that's type of hypovolemic shock. Again, the body will compensate for the volume depletion by raising your heart rate. So you're going to have tachycardia. As a rule of thumb, if you have a patient who is hypotensive, you want to check their heart rate. Okay, if they're hypotensive but their heart rate is fine and the patient looks fine, they're usually okay. But one of the signs that the body is compensating for a problem is if you have low blood pressure and a rising heart rate. That tells you that your patient's not well, patient's unstable. So again, with hypovolemia, you're going to have tachycardia to compensate, to try and maintain the cardiac output. So remember, cardiac output is heart rate times stroke volume. With hypovolemic shock, though, your JVP will be lower just because you have less volume in your circulation. So you'll have less blood, lower JVP. And again, peripheries will be cold because you're peripherally shut down, you don't have fluid. So the way to treat hypovolemic shock is to give the patient fluid, plus minus blood. All right. Distributive shock is the only one that we call warm shock. Okay, and I'll explain why. Distributive shock is you have some sort of process that's causing peripheral vasodilation. It's causing your blood vessels to dilate, and in doing so, that drops your blood pressure. Okay, and that obviously is going to compromise perfusion to your organs. And the key example for this is anaphylaxis. You have a massive inflammatory response that's causing vasodilation, drops your blood pressure, and patient is very unwell. Again, you're going to have the compensatory tachycardia. And here the JVP will be lower just because all the blood vessels will be dilated. All right. And we call this warm shock because the peripheries are going to be warm. Why? Because you have vasodilation, and you probably have increased blood vessel permeability as well. So you're going to have blood and inflammation, which causes warm peripheries. Then you have obstructive shock. So that's because there's something that's essentially blocking the blood flow to the rest of the body. There's an extrinsic obstruction. Okay, for example, a PE. All right. You'll also have a tachycardia. You'll have a really high JVP if it's a PE, because again, you have a backlog of blood, and this will be cold peripheries as well. Okay, that's your type of shock. And you basically treat the cause and try and fix their blood pressure. All right, let's go through BLS and ALS. You have to know BLS well for third year. You don't have to know ALS as well, but I find it interesting to know, and it will help you to understand if you ever go to a code blue or you have an ICU rotation or anything like that. Helps to know ALS. You will learn ALS properly in 5th year. Okay, so for basic life support, again, it used to be an OSCE station, won't be tested in 3rd year that much unless you have a clinical skills assessment of it, but it will be tested in your year 4 GP Apex. Doctors A, B, C, D. And if you ever do a simulation, if you come to a MECCSIG workshop or you're doing simulation in your clinical skills tutorials, make sure that you commentate all your actions, speak out loud. You know, I'm checking airway. Okay, airway is patent, checking the breathing, patient's not breathing, so on. So try and speak out loud. It helps to communicate with your peers who are going to be helping you in the scenario, and also shows the person who's teaching you that you know what you're doing. Okay. Again, as we kind of touched on before, how you manage it in the hospital is different to how you manage it in the community. Okay. Yeah, and just know BLS well, and you can learn ALS for fun now. So with BLS, remember your compressions, you want to do 30 compressions to 2 breaths, and you want to compress the middle to the lower half of the sternum. Common mistakes people do is they push too high or too low. If you're pushing too low, you're not really pressing on the patient's heart. The point of CPR is to not restart the heart. The point of CPR is to circulate blood to the brain until you can get the heart beating again. Because the first organ, or one of the first organs to die in a cardiac arrest, is the brain. It can't survive very long without oxygen. So you want to do really effective compressions. You want to press 1/3 of the chest, and you want to compress to the rate of 100 to 120 compressions. So if you go to the songs Staying Alive, so Staying Alive, and new one you can use is Baby Shark, but Are You Staying Alive? Okay, you want to position yourself such that your shoulders are above the patient. Okay, so if this is the patient, you want to have your shoulders over the patient such that you can have your arms nice and straight. You want to lock your elbows and use your whole body weight, your whole upper body to compress, especially if you're somebody small like me. Like, please feel free to literally get on top of the bed and go on top of the patient and compress that way so you can get the strength that you need. Okay, it's much better to push harder than you think that you need to. Okay, common to break ribs, it just means that you're doing a good job. Better somebody with broken ribs than somebody who is dead. Then in terms of ventilation, so you have the bag valve mask, which is that mask that kind of has like a triangle shape, which goes over the nose and mouth like so. And you want to achieve a really, really good seal, okay? And you have your bag to squeeze. You've probably done this in clinical skills, okay? In the community, you can do mouth to mouth. But if you don't want to, that's totally fine. It's mostly the compressions that we care about. Okay. Compressions, again, don't restart the heart. They're just circulating blood to the brain until we can get a defib to try and see if we can shock the heart into a normal rhythm again. Ideally, you want to have uninterrupted CPR. So if you're in a simulation with other people and somebody is getting tired, you want to have somebody to swap out with you, and you want to minimize the time in between the compressions. So somebody should go straight into compressions if you're finishing up. Okay, so now I want to talk about the 4 H's and the 4 T's. So this is part of the ALS, right? Is to think about what are the reversible causes of cardiac arrest that I could treat to get this patient to become stable again with a pulse. It's beyond the scope of 3rd year probably, but it's good to know, and you will have all the tools and all the knowledge to be able to understand it. Okay, so 4 H's and 4 T's, very easy to remember. The H's are hypoxia, hypovolemia, hypo or hyperthermia, and hyper or hypokalemia or glycemia. So the electrolyte disturbances. Okay, so hypoxia, if there is something preventing them from ventilating or from oxygenating adequately, you treat them with 100% oxygen and probably intubate them, which would normally happen anyways as part of a resus. Hypovolemia, so again, they volume deplete like we talked about. You want to obviously get good access, so insert 2 large bore IV cannulas, give them fluids, plus minus vasopressors, plus minus inotropes, plus minus blood transfusions. Okay, and if they have an ongoing cause of active bleeding, for example, they're bleeding into the abdomen, then you take them urgently for surgery. With hypo or hypothermia, you obviously correct that by either warming or cooling the patient. Fun fact for you, if somebody who is hypothermic, who's really cold, has no pulse, you actually can't declare them dead until you bring them back to a normal temperature, attempt to resuscitate them, and that's unsuccessful. That's a cool fact for you. And of course, the electrolyte disturbances, so you would do a VBG quickly, and that would give you information about that, so you can correct it, so to stabilize the heart. Then the 4 T's are thrombosis, tension pneumothorax, tamponade, and toxins. Thrombosis means there's a clot somewhere that's preventing the heart from being able to pump properly. So acute coronary syndrome, patient having a heart attack. So you usually do an ECG to find this out. The ways to fix it, PCI, obviously, as you've learned this year, or if you can't access PCI in time, or the patient's not close to a cath lab, then you would do thrombolysis. If it's a massive PE, for example, saddle PE, and you can usually find that out because you would do an echo of the heart and you'd see signs of right heart strain, then you would you'd proceed to fibrinolysis. Tension pneumothorax, so remember the signs of that would be deviated trachea, so absent breath sounds, hyperresonance to percussion, and you would treat that with a needle decompression or a finger thoracostomy in the acute setting. So in terms of the needle decompression, as I said, that's the initial management, and you would insert like a small needle into the second intercostal space. So you would find the sternal angle, move to the side where it's affected, the second intercostal space, and at the midclavicular line. Okay, so insert a small needle, like a small catheter, to basically let air drain in the short term. Paramedics will usually do this if they think the patient has a tension pneumothorax. And then the definitive treatment, as I said, is a chest tube. So you insert it into what we call the triangle of safety. So here it's this area over here that's bound by the lateral edge of the pec major and the anterior edge of the lat dorsi. So 4th or 5th intercostal space between the mid-axillary to the anterior axillary line. And if you've watched the first episode of The Good Doctor, then you would have seen this like a makeshift chest tube in action. Okay, so that's your tension pneumothorax. Tamponade, so cardiac tamponade. So things to make you suspect cardiac tamponade in the history of the question is patients had chest trauma. So the trauma has pierced the pericardium and is causing there to be a bleed in the pericardial sac. Okay, so cardiac tamponade is you have usually blood or fluid accumulating in the pericardial sac, so much so that the pericardial sac itself can't expand very much. So the fluid or the blood is accumulating in that sac putting pressure on the heart, and now the heart isn't able to expand and pump properly, patient can die very quickly. So a chest trauma would be a risk factor. If the patient has had a recent heart attack or PCI, and you would know this from your first pathology exam, because one of the complications of a heart attack or a PCI is you have a ventricular rupture. So the ventricle will rupture, and obviously that will cause blood to move from the heart into the pericardial sac, causing cardiac tamponade. If the patient has a dissecting ascending aortic aneurysm, so over here there's been a tear in the blood vessel that's causing blood again to accumulate in the pericardial sac, severe pericarditis, as well as a few others. Symptoms: chest pain, shortness of breath, probably syncope, very unstable patient. Signs: this is called Beck's triad, so commonly tested actually in third year. So a patient will have low blood pressure. Why? Because they're having cardiogenic shock, like we talked about. The heart is not working as a pump very well. And then because you're in cardiogenic shock, there's going to be a backflow of blood into the internal jugular vein. So you're going to have distension of the jugular veins. And then because there's fluid surrounding the heart, you'll put your stethoscope on the patient, and there's muffled heart sounds. You can't hear the heart sounds very well because there's fluid there. There's fluid in between the heart and your stethoscope. So if you think about trying to speak or trying to make sounds underwater, you can't really hear very well. So that's why you have muffled heart sounds. And then you do an ECG, you can find tachycardia, and sometimes you can find something called pulsus alternans, which the amplitude of the QRS complex is high and then smaller and then big and then smaller, big and smaller. But that's just a rare buzzword for you. Okay, so that's cardiac tamponade. How do you treat it? Pericardiocentesis. Basically stick a needle into the pericardium and you suck out that fluid to give the heart the chance to expand. So that's tamponade. And last but not least, toxins. So has the patient taken anything toxic that has caused them to go into cardiac arrest? And then you want to think about what could it be, and you look for the signs of certain types of overdoses, and you would give the relevant antidote agent. So see, it's pretty easy, and you know how to answer the questions now. Okay, so for ALS, usually we have a look at the heart rhythm and we say, all right, can we shock, or is this not a shockable rhythm? The two shockable rhythms are VFib and pulseless VTach. So VFib, you have an irregular broad complex tachycardia. Remember B for bad. Broad is bad. So anytime you have a tachycardia, broad is bad. That's a hack for you as well. And pulseless VT. So VT usually is a regular broad complex tachycardia. Okay. That's your shockable rhythms. That means that if you shock them, there's a chance that it will actually revert back to a normal rhythm. So they are obviously a more favorable diagnosis compared to a non-shockable, because there's something that you can do to fix it. Okay. Then your non-shockable rhythms. So you probably heard this from the TV shows. So the flat line, which is asystole. It's a sign the heart's giving up. You can't shock it. You can only treat it with adrenaline, but it's usually poor survivability. And then there's PEA, which is pulseless electrical activity. So there is some activity still in the heart, but there's no cardiac output. All of these rhythms, by the way, are pulseless. Okay, so you find a pulseless patient, you pop the defib on, and you would see this. Now, common thing to get mixed up is the different forms that are on the defib. So if you set it to the AED, that's there's automatic defib. That's the one that you'd use in basic life support. So what it does is the defib will check the heart rhythm, and it will recommend shock or no shock depending on what it detects on this slide here. So that's the one that you use in the community. In the hospital, though, they would have it on the manual setting, and they will choose to shock and how many joules to shock essentially. But this is all you need to know. Okay, so the shockable rhythms: VFib, pulsus, VTach. And non-shockable are asystole and PEA. You can only treat those with adrenaline and continuing compressions and trying to get some sort of improvement. But it's better to have a shockable rhythm than a non-shockable rhythm. All right, let's have a look. For the following patient with a cardiac problem, suggest the most likely arrhythmia. 50-year-old man with central crushing chest pain, collapses in the ED, a code blue is called, and he is found to be pulseless. So we're looking for a pulseless arrhythmia. What's the most likely one? This one is a bit tricky because you're probably between two options. The answer here is VFib. So I'll explain why. First of all, VFib is more likely to be pulseless. VTAC, as we said, can be pulseless, or it can be in a conscious patient who still has a pulse. So it's more likely to be VFib because VFib is always pulseless, always unconscious. Okay. And secondly, central crushing chest pain, we're probably thinking he's having a heart attack. He's more likely to go into VFib because of that as well. Okay. In terms of AFib, sinus brady, atrial flutter, sinus tachy, all of the others, you wouldn't be pulseless. Okay. So that's this question. A code blue alert is sounded. As you race to the arrest, you remind yourself how to perform good quality CPR. Select which of the following is not an aspect of high quality CPR. Have a read. The answer here is D. So you want 30 compressions to 2 breaths. Okay, this is the wrong ratio. A is correct because you obviously want to have continuous CPR if you can. You want to push to the adequate depth, and the rate that you're aiming for is 100 to 120 beats per minute. Okay. 68-year-old man reports several episodes of chest tightness that last for a few minutes before it self-resolves. He has a small troponin rise. He has no past medical history. Proudly states he has never had a need for a GP. Red flag. He is admitted to the cardiac ward with an NSTEMI and is on telemetry. The alarm from the central monitor alerts you, and you go and see the following strip on the rhythm strip. Select which of the following options is most likely. Have a think. Answer here is, it doesn't say. Answer here is VTAC. Okay, so it's a regular broad complex tachycardia. It's VTAC. Torsade de pointe, it's not as regular in terms of amplitude. So there's like it will be small amplitude then larger than smaller and larger. And VFib is also like an irregular broad complex tachycardia. Cool. So we'll just talk quickly about the different types of blood products and transfusions. This sometimes gets tested on the past papers. So it's good to know, but don't feel the need to know in too much detail. Okay. So you first of all have whole blood. That's giving somebody all the components of blood. It's rare. It's rarely done. If you guys have ever been in like major surgery, you'll see something called the cell saver, which is basically the patient's blood in the suction, and then it goes through a machine that will filter the blood, and it can be given back to the patient. Okay, so that would be an example of a whole blood transfusion, but it's not usually transfused. The commonly transfused ones are the red blood cells. Okay, so it's just red blood cells. So indications for this would be patient who's having an acute hemorrhage, is extremely anemic, symptomatic, or has severe anemia. And when you give 1 unit, so 1 pack of red blood cells, you would expect hemoglobin to rise by 10 grams per liter. Okay, if it's not rising according to that trend, you should probably start thinking they're still losing blood. Okay, fresh frozen plasma, so that's plasma and all its components. So it includes clotting factors. So the indications is if patient has had an overdose of warfarin, which means that their factors 2, 7, 9, 10 are lacking. Clotting factor deficiency. So for example, if they have such severe liver cirrhosis where they're not producing those proteins that are normally circulating in the blood, and if they're in a state of DIC, and it's also part of the massive transfusion protocol, which I'll touch on in a sec. And then you have just pure albumin, which is a protein that makes up over 50% of the proteins that normally circulate in our plasma. Why is that important? Because the proteins in our blood are what maintain its colloid pressure. So basically keeping fluid in in the blood vessels through the principles of osmosis that you would have learned back in first year. Okay, so there's different concentrations you can give. Don't worry about the concentrations, but just learn why we would give it. So if somebody has had an acidic tap, if they've had severe burns, and then hypovolemia, hypoalbuminemia, hypoalbuminemia, can't pronounce that. And that would be, for example, if somebody has severe cirrhosis and their liver is not producing any albumin, that would be an indication. Okay, then we have platelets. That's if the patient has significant thrombocytopenia, because that puts them at an increased risk of spontaneous bleeding. Can also be given in your massive blood loss. And then cryoprecipitate is your clotting factors. It's similar to fresh frozen plasma, but it's preferable if a large volume is not suited. So still warfarin overdose, clotting factor deficiency, don't worry too much about it. And you can also give specific clotting factors if somebody has a specific deficiency, hemophilia, for example. Okay. With all of these products, you want to remember about RUSUS and about ABO compatibility. So you don't want to give somebody the wrong blood product or a blood product that can cause them to have a severe reaction. Okay. So you guys will have learned this year, there's a blood test called Group and Hold, which will test the patient's blood group and will keep the relevant blood in storage in case they need it. Okay. In emergencies, if we don't know the patient's blood type, we just give them an O negative because it's the least likely to cause any transfusion reactions. Okay. So if you're O negative, please go donate blood. You are going to be incredibly useful to the hospital. Okay. When do we transfuse? So as we said, the blood cell transfusion is if somebody has clinically significant anemia, if they're symptomatic or if they're having ongoing blood loss. But we take a combination of the patient's clinical state as well as the blood test hemoglobin level. Okay, so usually if hemoglobin's above 100, don't transfuse unless there's a rapid declining hemoglobin. Between 80 to 100, we can give. 70 to 80, give. If it's less than 70, give for sure. Okay. But again, don't worry about this. It doesn't get tested. It's just for your knowledge. Okay. Then there's this thing called the MTP, mass transfusion protocol. Okay. That's if patient is so unwell, right, that we're needing to replace their whole blood volume in 24 hours. So the proximate blood volume in an adult is 70 mils per kilo. Or if we're having to replace greater than 50% of their blood volume in 4 hours. So it's a protocol in every hospital, and the reason it exists is to mobilize the appropriate blood products ASAP. Okay, so usually patients in hemorrhagic shock, they're really unwell, critically bleeding. Okay, it's quite complicated, so I won't go through the whole thing, but there are obviously issues with transfusing a whole bunch of blood suddenly. One, the risk of kind of overshooting, and you cause the patient to go into a state of volume overload. Hypothermia, if the fluids we're giving aren't warmed appropriately. And there's also this thing called dilutional coagulopathy. What that means is we've given so much fluid that we've essentially diluted their blood, and it might look like they have lower platelets or lower clotting factors, etc., than normal. Okay. And there's also, of course, the risk of all the different transfusion reactions. You might have touched on them in second year. You don't need to know them now. Just know that they exist, and they are always a risk if you're transfusing anything. Okay. So the signs of a transfusion reaction: shortness of breath, tachycardia, hemodynamically unstable, wheezy, having a fever, feeling nauseous, feeling generally unwell, pain at the site of the infusion at the IV, or any bleeding from the IV. How you would treat this makes sense to immediately pause the transfusion. Okay. And you want to check that you've given the right product to the right patient, because it could be that you've given the wrong patient's blood and that's why they're having a transfusion, or they're giving the wrong, or you're giving them something that they're allergic to, etc. If it's a mild transfusion reaction, you can just give them an antihistamine, see if that improves it. If it's a severe reaction like anaphylaxis or a specific type of transfusion reaction, then you would just follow that protocol. Okay. Transfusion reactions can happen straight away, or it can happen after 24 hours. And now we're just going to talk about fluid management. No one taught me this properly in third year. It's probably very helpful to know. You won't necessarily get tested on the specifics of it in third year, definitely not. But I feel like it's just helpful to know. Hopefully I can summarize it for you quickly, but it is a very complex topic. So I have provided some links in the comments section of these coming slides for you to read up if you're interested. But don't stress, it doesn't come up on exams in any sort of detail. Okay. Why do we care about fluids? There's 3 reasons why we would care. 1, if the patient needs fluid resus, okay, so we need to give them volume. 2, for maintenance. So if they have to fast for surgery, so the nil by mouth, you still want to make sure that they get the electrolytes that they need. And if they're having an ongoing loss like vomiting and diarrhea, these are all reasons why we would prescribe somebody fluids. In terms of resus, so the point is just to get the volume up, all right, in the circulation. So normally we give a bolus of normal saline. In a healthy, normal adult, we'd give 500 ml bolus. So bolus means straight away. It's not over like a certain amount of time. If somebody's really frail and old, we just want to be a bit more careful. So we give them 250 ml bolus. For maintenance, right, because we're going to probably substitute this instead of their food, right? So we care less about just volume and more about giving them the right electrolytes that they need. Okay, so we care about water, sodium, potassium, chloride, glucose, things like that. Okay, the average 70 kilo adult will need about 2 liters a day of fluid. And for maintenance, it will depend on the patient and it will depend on the situation. So I can't really give you a perfect hint for this, but it'll be a combination of normal saline, Hartmann's, 5% dextrose. And I have a slide coming up that shows you the components of each one of those fluids in case you're interested and you want to know what's in that bag that the patient is getting. Okay. And then also for replacement of losses, you're probably using the same combination of drugs. If the patient is able to tolerate fluids like drinking or eating, then you want to start there. And then if they can't keep anything down, then you go to IV therapy and you want to monitor their electrolytes. So here is the composition of different types of IV fluids. This is your normal plasma, so normally in your blood. And then different types of fluids you'll see, normal saline, 5% dextrose, Hartmann's, and don't worry about this one. You don't have to memorize this at all. This is just for your interest. And I have some links in the comments below in case you want to read up about how we prescribe fluids. Okay, so let's have a look at this question here. For the following patient, select the most appropriate initial therapy. A 60-year-old man with cirrhosis has undergone abdominal paracentesis for tense ascites. So that means an acidic tap. He's had ascites in his belly and they've drained all that fluid out. His blood pressure is currently 95/50. On examination, he is awake, alert, and oriented. His abdomen is moderately distended, but soft and non-tender with a paracentesis catheter in situ. Okay. 5 liters of acidic fluid in his drainage bag, and the bedding surrounding his catheter is wet. So quite a lot of fluid. He has pitting edema to his knees and crepitations at the lung bases bilaterally. His renal function is normal. Albumin is low, 18 grams per liter. Hemoglobin is also low, and sodium is slightly low. What do we think this patient needs? The answer is he needs albumin. So this guy has clearly very bad cirrhosis, and it's the liver's job to produce the albumin to keep your colloid pressure in your circulation, to keep fluid inside your blood vessels. If you don't have that albumin inside the blood vessels, the fluid through the process of osmosis will just leak out into the surrounding tissues, and that's what's happened to cause his ascites, to cause his pitting edema to his knees, and also the fluid in his lungs, pulmonary edema. So how to fix this is to give him that albumin to encourage the water to go back into the blood, and to relieve all those symptoms and to prevent him from getting further ascites. Also, the fluid of choice after somebody has had an acidic tap is to give them albumin. Most appropriate management plan. 55-year-old man who has been taking Voltaren for a knee injury he sustained 2 weeks ago while playing golf presents to the ED with a sudden onset of severe epigastric pain. This is a very common question in third-year exams. On examination, he has a rigid abdomen. His temperature is 38, his pulse is 100, and his blood pressure is 100 on 40. The erect chest X-ray shows free gas under his diaphragm. What do you want to do? Okay, so let's go through this. This man has been taking Voltaren. We can assume the tablet form of Voltaren, okay, which is an NSAID. He's probably been taking the NSAID nonstop because he's in pain, and that's caused him to develop a gastric ulcer. Okay, so that's the epigastric pain. However, this is complicated by now we're seeing signs of perforation of that ulcer. Okay, so what are the signs? He has a rigid tummy, so he's peritonitic, he's got a fever, he's mildly hemodynamically unstable, and we saw on the erect chest X-ray, so chest X-ray upright, that he has gas under his diaphragm. So there's free gas in the abdomen. He's got a perforation. Okay, so there is no time to waste. You need to call the general surgeons very quickly and get him into surgery ASAP to repair the perforation. That's probably the priority, and that's why D wins, because he needs urgent surgery. Okay, there's no point doing a CT scan. You probably have an idea of what's going on. You don't need the time taken to wait for the CT scan, the time to do the CT scan. You have the X-ray, it's clinically unstable, just go straight to theater. Okay, and you just want to give him some fluids to keep him stable, because his blood pressure is already starting to become low, and if he's going to have surgery, his blood pressure is going to drop. All right, like we talked about, because of all those medications and agents that the anesthetist will use, will probably drop his blood pressure as well, and he has to fast. So all of these are reasons to give him fluids. Last but not least, basic toxicology. Sometimes it comes up on exams, also helpful if you have an ED rotation. Here are the common drugs that patients can overdose on or take too much of. And here are the buzzwords, and here are the treatments, okay? Paracetamol, it's very accessible. So if patients want to consume a lot of it, they can. The treatment is NAC, and there's a protocol depending on how much paracetamol they've taken and the level in their blood and how long it's been, so I won't go through that. Common ones that could come up, warfarin, remember? So confused elderly person, probably because they're most likely to be on warfarin. In the acute setting, you can give them fresh frozen plasma to give them the clotting factors, or if it's not too urgent, like it's not too acute, you can give them vitamin K. All right. If it's an opioid overdose, either post-op, they've been given opioids in surgery and they're quite sensitive to them, or you find somebody on the street who's got pinpoint pupils, they're having an opioid overdose, so you give them the reversal agent, which is naloxone. If somebody is quite dependent on alcohol, they will start to withdraw if they don't have that alcohol. Okay, so if they're having an acute withdrawal, you treat that with diazepam, which is a benzodiazepine. And also you want to give them thiamine, which is vitamin B12, which is a vitamin that people who are alcoholics lack. And that's to prevent a complication called Wernicke's encephalopathy. Okay. Other ones, I don't think you need to know too many. And just know that there is an antidote if somebody has an OD on digoxin. It's a monoclonal antibody. Okay. I have this logo up here because there's this beautiful app to anybody who wants to look into this further, who has an ED rotation or who's just interested. It's a toxicology app from the Austin Hospital. It's free, and it provides you with protocols for an overdose on so many different types of medications. So it's pretty cool if you're interested in that. And that's it from me. I just want to touch on what MECCSIG is. So we're the Emergency Critical Care Special Interest Group of Monash. So anybody who's interested in anesthetics, ED, ICU, trauma, we're the subcom for you. We usually have workshops, webinars about careers, and quite a lot of educational material through fact sheets that we put out on our Facebook group. So keep an eye out on our socials. In 2025, we have a few positions that 4C students next year can apply for. So keep an eye out for those timelines on Facebook. These are the references. If you're interested in anything crit care, these are your go-to places. Thank you very much for paying attention to me talk for this long. Hope you enjoyed it. Hope you learned something. If you have any questions at all, please feel free to email me. That's my email on the screen. You can message me on Facebook. And I want to also, again, give credits to people who gave this lecture in the past, and I basically just took their slides. Thanks very much, and I will see you at the Q&A session that is later on in the year for some live question and answer. Thanks.